So right now in Canada, there are three main options. I think that the most prevalent is the use of lenalidomide and dexamethasone. There would still be a proportion of centers that use Velcade, melphalan, and prednisone, and then Cybor-D, which is cyclophosphamide, Velcade, and dexamethasone. Those are the three primary treatment options for transplant-ineligible multiple myeloma upfront patients. Most of our patients right now are treated with lenalidomide and dexamethasone. There'd be a subpopulation treated with Cybor-D. Predominantly, we use that for sicker patients, in-hospital patients, or renal failure. The ALCYONE trial was a phase 3 trial that looked at Velcade, melphalan, and prednisone versus that standard of care with the addition of daratumumab. That was the experimental arm in transplant-ineligible patients as an upfront treatment. Dr. Demopoulos presented the 1-year further updated results on this trial and had an improved hazard ratio showing a decreased risk of progression or death by 57%. The median progression-free survival for the daratumumab arm hasn't yet been reached, but for VMP was 19.1 months. More impressively was the MRD rate. That MRD negativity in this elderly population was 10% versus 2% in the VMP arm. I think that the daratumumab doesn't seem to add any increased safety signals based on this updated data. Well, certainly the addition of daratumumab to any treatment has shown an improvement in progression-free survival. We see that in the relapse setting, and hopefully now, when we can get it in our hands and it's funded, will definitely be a part of what we want to do for upfront treatment in our transplant-ineligible patients. I think that's been seen in a couple of other trials, the Lyra and the Griffin trial. So adding daratumumab to any part of our upfront standard of care will be a benefit for patients.